Hi, everyone. This is my lecture on working with children with special needs for week 9 in our course module. You will be doing your observation of a child at play with some type of special need in week 10. So this video is in preparation of that observation and to supplement some of the information that you were given in this week's readings. Specifically, I want to talk about autism spectrum disorder. I have pulled up the link to the diagnostic criteria. This is from the Centers for Disease Control and Prevention, the CDC, and it is the diagnostic criteria for autism spectrum disorder. So only reason I have it pulled up is because I just would like you very much to take a look at this. This is updated information from what the Frost et al. Textbook is giving you. So remember that the Frost textbook that you're reading from was published in 2010. It is now 2022 when I'm recording this lecture. So you can kind of think on that. The DSM-5 criteria was updated in 2013 based on research and data that was collected on autism spectrum disorder by that point. And it was a refinement of the criteria that also changed the criteria significantly. And now we have found that that diagnostic criteria is much more stable than prior criteria. So remember that when you think about what you're reading with the textbook. The textbook having been published in 2010, think about how much time it took to put together that research to create that textbook. And you can imagine that that textbook information was already several years old when that was published. So 3 years post publication of the textbook was then, the publication of the DSM-5. I know that the DSM-6 will be published soon, although I have not read or heard any information on whether or not there will be more refinement or change to the diagnostic criteria for autism spectrum disorder. So there are some key changes to the DSM-5 criteria. I first want to talk about something that the textbook says, and that is that the textbook describes autism as can be pervasive developmental disorder. It can be Asperger's, or it can be, I think the way they refer to it is, autism. And they're basically sort of parsing out the diagnosis. So that is not really how autism is referred to anymore. It is referred to as autism spectrum disorder. There isn't a breakout for Asperger's or pervasive developmental disorder, or PDD. Those are all rolled into one. That's why it's called a spectrum disorder. It's very broad. There are 3 levels. Level 1, if you read more in the CDC website, you will find that there's quite a bit of information on the deficits, and they have to have at least 2 of the 4 types of these restricted repetitive behaviors. You can read more about this on your own. I don't want to necessarily read it to you, but again, going back to that level 1, level 2, and level 3. Level 1 is the least disrupted. So level 1 means that a child or an individual with ASD will require a little bit less support. Level 3, being the most severe, means that the person with ASD will require the most support. They'll most likely be nonverbal and have significant disruptions across all areas of development. What I'd like you to think about is that when we characterize autism spectrum disorder, we are using diagnostic criteria, meaning that we don't at this point have a genetic test. We don't refer individuals for an MRI to examine their brain. Recent research that has come out now is showing significant differences in the way that the person with autism spectrum disorder, the way that their brain functions relative to a person who is neurotypical. That you often hear those terms, neuroatypical and neurotypical. And I'm sure many of you are already familiar with those descriptors. So again, going back to ASD, it is not something that we can refer a parent for, just go take this blood test, or like, for example, with Down syndrome, a geneticist will, take do a genetic test for a family if a child is suspected of having Down syndrome, and that diagnostic test, that genetic test, will then confirm what the doctor maybe sees, the child presenting with, those syndrome type things that they're presenting with. But that's not the case. Excuse me. It's not the case with autism spectrum disorder, unfortunately. There, in research right now, we are seeing more discussion of, we may well be on our way to a genetic test. Because here's why we think that. And I can tell you from my own experiences in working with individuals with ASD over the years, there is heritability. We do see that because much of the research that we do with developing children who have ASD or who are suspected of ASD, the criteria for entrance into those studies is that they have to have a sibling who has been diagnosed with autism spectrum disorder. So the research that I operate from in my practice with children with disabilities as an early intervention specialist is based on that research, where an older sibling is diagnosed, the younger sibling is born, and then there's research done to determine what are those possibilities. Are we seeing, how early can we identify children with autism spectrum disorder? So it's interesting, all of the research that's coming up, that's just come out. There is now MRI data that shows that children with ASD do their brains do light up differently than typically developing children. So one of the things would be that we know that children with ASD, or individuals with ASD, the part of their brain that lights up when they engage in social interaction, it just doesn't light up like it does for objects. So people with ASD tend to prefer looking at objects over engaging in eye contact. And so research has taught us that one of the things that we can see very early on is at 2 months old, there's something that happens with infants. And so think about what's happening with children visually in that newborn period right after birth. They don't see very well. They can see pretty close from being held in the arms right up to the face. They don't need to see very far, but everything's very fuzzy, and vision continues to develop. Well, with children with ASD, there's a huge difference at 2 months old, because we should be able to see very well. And what we see is that at 2 months, typically developing infants, if you were to chart their eye contact, it goes just like this, just straight up. The chart just goes way up. However, with children with ASD, that chart would go straight down. You would see a decline in eye contact. And so that's one of the things that we consider in doing intervention is I'm using a naturalistic program with the families that I work with that have children who are either suspected of having autism or have indeed already been diagnosed. We are using that lack of preference for eye contact we're trying to change that. We're trying to mold their preference and change it so that, because what other research shows us is that individuals with ASD, as they age, eye contact, because it's not preferred naturally to them from a neurological standpoint, they then become anxious when engaging in eye contact with people. So we really want to structure the environment in such a way that we foster and we reinforce eye contact, so that eye contact becomes a much more pleasing thing for these children. So obviously, because of what we learned about neuroscience and development, what we know is that we've got this sort of really plastic time in neurodevelopment, right? So we know from birth to about age 5, that's our really crucial, really critical time when we want to really reinforce eye contact. So that's what I do. I go out and I use a program called Pathways. It's a naturalistic, family-focused program where I literally am working with families to really see the importance in eye contact, and also to learn how to do using applied behavioral analysis techniques. It's based on the principles of ABA. For those of you who are familiar with ABA, it is not an ABA program, but it's based on some of those principles. We are reinforcing eye contact, and a lot of that is just teaching parents to sort of be, following the child, and in sort of getting in their face and helping them to have. It sounds kind of negative when I say it that way, but we're really teaching families to sort of get in there and follow their children's eye contact, and then to reward it. So let me give you an example of what that would look like. So with one of the families that I see that have two children already diagnosed with ASD, our first, well, it's really week 3 in the program. It's a 12-week program. So week 3 in the program is where we are using social sensory routines. And so we'll have already established a time when the children are going to come and sit with their families through a program, or the week 1 program, which is focus practice. And then week 2, we're really focusing on eye contact. And we're also doing some activities to encourage the children to respond to their name. So in week 3, we're doing social sensory routines. And so one family that I see with the two children that are already diagnosed, they have a spinning chair that the kids love. And so what we've learned, or what I've taught the families to do, this is how we've turned this fun routine into a reinforcement for eye contact, is we have one of the kids to sit in the spinning chair. Dad sits in front, holds the chair so that they can't spin it themselves. And then as soon as they make eye contact, just even fleeting eye contact, he spins the chair and it comes back and he holds it. And of course, the kids love it. They get big smiles. And they are learning, if I look at dad, he's going to spin this chair and do this fun thing that I like. So again, it's look, spin. And I'm usually standing behind, sort of timing how much time are we getting. At first, when we were starting to do this, we were lucky to get maybe 3 seconds of eye contact. So even fleeting eye contact, we reward. But we've gotten much further. And now in my visits, dad is telling me that the children are actually in, like, they're seeking eye contact because we've made it this fun thing. And the beautiful thing for me is, I'm there during birth to 3. So I'm right in this perfect time to capture eye contact in fun, sensory seeking ways. But also, it's what we've learned from this neuroscience and the data that's come out of the use of these naturalistic programs is that the children's brains actually change. Not only do we avoid anxiety that would typically be associated with eye contact, the children are actually, their brains are wired now differently. And that's the beauty of plasticity. So neuroscience helps those of us in the field because we are learning to do things differently and actually change the outcomes of these children. And if I sound like I'm a little bit excited about this, is because I am a big believer in early intervention. I do this for my day job, and it is fascinating for me to go out into these homes and to bring this really wonderful and hopeful program to families. Because, to be honest with you, as a former special education teacher who worked with children with autism spectrum disorder, if I had had this information going in, I would have certainly structured my classrooms very, very differently. And I wouldn't have focused so much on academics until we really spent more time on joint attention and social sensory routines, and on just getting that eye contact, especially with our younger students. I do, again, want to encourage you to look through the diagnostic criteria, because so much of the diagnostic criteria is really based on not just communication, but on social communication, on reciprocity, and on some of the behaviors that the children or that individuals experience. Again, these are not something that show up later. This is, something that, this is something that's a neurodevelopmental disorder. So again, it affects development very early. And so children with ASD don't meet developmental milestones pretty much across all of the developmental areas. So it's a child who's typically going to experience some motor challenges. They're going to play very differently. They're going to again, like I've explained to you in the beginning of this, they're not going to make eye contact. It's not their preference. They're going to make very little of it unless it has already been reinforced a great deal. Um, Communication is always delayed with children who have ASD. It's part of the red flags for autism that we use in early intervention when we are concerned. Anytime we have children come into us who are delayed in their communication, even though in the early intervention world, we know that specific language impairment is the most common developmental disorder or developmental delay. We still always do sort of a red flag, and our goals are meant to really address the potential for ASD by watching very closely over those first few months that we're working with these families. We want to make sure that if a child does have some of these strong red flags, these symptoms for ASD, that we are providing very specific type of intervention, because our time for improving outcomes is so short, frankly. Um, Intervention changes once children leave that birth to 3 program, or even the 3 to 5 program. And some of the really challenging behaviors that some of the children with ASD will have become harder and harder to mitigate, and harder to fade out. So it's important that children with ASD or suspicion of ASD are receiving early intervention. And specifically, research shows that the more naturalistic, if it's family focused, it's something that the families are doing all day long, every day, and people involved in that child's life are all engaged in this, it's the most successful type of intervention. So again, I wanted to update you on the information. I strongly encourage all of you, no matter what field you intend to go into, whether that's child life or OTPT, or if you want to be going in, if you want to go into teaching or something like this, or if you're interested in early intervention, I strongly encourage you to update your information on autism spectrum disorder. I'm not saying don't, I don't say throw out the book, our textbook completely, but just, bookmark that the information on ASD is outdated. And it's a good idea, especially if you do intend to work with children with any kind of disabilities, or you're going to work with children generally speaking, especially in education, that you are aware of some of the changes in research. Genetic research as well as neuroscience have really changed the face of our understanding of children with disabilities. Another example would be that when I started out working with children with disabilities in the 90s, after I got my master's in human development and early childhood disorders, we had a certain amount of knowledge of genetic conditions. So Down syndrome being, probably the most predominant genetic condition that we're all aware of. Well, now we've got the human genome mapped for, I guess close to a decade, or maybe a decade now. And so we know quite a bit more about even Down syndrome, how it can be manifested in in multiple ways, not just this one particular kind of monolithic way that we thought. So it's good to stay abreast of what research is out there. The other thing I want to say about ASD, and then I'm going to, leave that, is that the CDC, when they did their most recent sort of census, it's not a census really, but it's just kind of that, where are we in the world with regard to autism? How common is it in the world? And there's been this awareness of, the increase, the uptick in the number of children who are diagnosed now with ASD. And bearing in mind, again, we have known for a while that early intervention is best practice for children with ASD. But there's this concern now, like we have all this information, and the CDC has gotten to be really concerned about development. And so they have actually ordered, they're in the process of gaining and you know, approving all these different studies that will look more into autism spectrum disorder. So my anticipation is not only will we eventually have a genetic test, I think we're going to learn a lot about how other things impact uh, autism spectrum disorder. And so it's possible that within the next 10 years, we could see the diagnostic criteria really change. And like all, uh, genetic conditions, anything that we suspect may have some sort of a genetic um, heritability in as a factor in the condition, it's wise to be aware of the ethical issues surrounding that. Because while as an early interventionist, I may think to myself, oh, this will be great if we knew at birth, if everyone just ran the diagnostic test, if there's a suspicion within the family of this genetic predisposition for ASD, if we knew very early on, before that 2-month mark, that a child did have this genetic condition, imagine what early intervention can be like. It could be so successful because we wouldn't have to rely on parent reports so much. It would just be a straightforward thing. But the other side of that I'm completely aware of is that just as we have this, genetic test prenatally for Down syndrome, what that has also caused is this vulnerability of, unborn children with Downs, that they are then extremely likely to be aborted, right? It's just from an ethical standpoint, we always have to be thinking about, all right, we could very well have a diagnostic or the ability to diagnose children with a genetic test, but then, the flip side of that is that we may have more parents also choosing then to not have children with autism. And so we just have to think about that too. Is the world, you know, better for that, or is it worse for not having neuroatypical individuals? And so, from having worked with neuroatypical individuals for so much of my adult life, I would say, I have my own opinion about that. And, the beauty that individuals, not just children, but individuals with autism has brought to my own life. So, it's something that I'm very aware of. Just, my own awareness is there. The other thing too is, I would say, with regard to working with children with disabilities in general, I have a tremendous joy that I get from doing the work that I do. It is, of all the jobs I've had, early childhood intervention is my favorite job. I would say that, it's been a lot of fun to go into people's homes and to work with them through the challenges, and also to find the joy that can come from, seeing children overcome the difficulties in their life and to succeed through things. I have seen so many really wonderful and just, almost miraculous things over the years. And there's a great deal of joy in that. And there's a great deal of joy in seeing children overcome challenges, just generally speaking anyway, but especially for these in this birth to 3 period of time. What I would speak to you about this is that one of the things I learned really early on, and it's really an infant mental health topic, is this idea that when we work with families from birth to 3, we're seeing children, just at the very beginning of their lives, and we're seeing families at the very beginning of their children's life. And so one of the things I became very aware of through the work of Selma Freiberg, she was a social worker who was very fascinated by psychoanalysis. And some of you, I mentioned this to you in your feedback with regard to when we talked about theory, some of you were very interested. Ugh, my hair. Anyway, some of you were very interested in psychoanalysis and psychoanalytic theory, and so not psychoanalysis, psychoanalytic theory. Anyway, some of you were very interested in that, and so I talked with you about check into Selma Freiberg's work. Well, as a young interventionist, before I had children and everything, one of the things I learned about was Selma Freiberg's work and how she used in her practice psychoanalytic techniques and this idea that when we meet families, that they are going to grieve their expectations. They're going to grieve some of the things that they experienced in their life when that child is born. It's going to be a loss when they meet the child that is not, this child that has disabilities is not what they dreamed of. And so much of my work is delicate in that my practice is focused on helping families to accept their child for who they are and also give them the hope that we can do great things together to help their children to overcome these challenges. So with that, I hope that you enjoy your observations of children with disabilities. I wish I could tell you so much more, but it's not a class on atypical development. And this lecture would be crazy long if I told you all the stories of all the things I've done out in the field. But anyway, maybe I'll weave some of that into my announcement time. I hope that you've enjoyed this, and I hope that this has been enlightening and given you some hope as far as what we know about about children with disabilities and how that's still changing and will continue to change. All right. Have a great week.